Dear viewers, welcome you all to our show, OSA, that is Orthopedic Solution Academy. Hope you all are well during this COVID-19 pandemic situation by wearing masks and keeping distance with each other. Dear viewers, today our topic is infection, a graveyard for all orthopedic surgeons. So, how can we control the infection? There is many other ways, but the ultimate way is ilizarov. So, our topic is infection controlled by ilizarov. And the speaker is the one and only, the legendary ilizarov surgeon in Bangladesh, Professor Mofakrul Barisar. I would like to request Professor Mofakrul Barisar to join with us.
Thank you very much. Good afternoon, everyone. Thank you, Tanveer, again. Okay.
Good afternoon, sir. Welcome to our show, OSA. Dear viewers, we have two learned academic experts with us. One is from Kurgan, Russia, the highly academic Professor Novikov, sir. I would like to request Professor Novikov, sir, to join with us.
Добрый вечер, дорогие друзья. Good afternoon, dear colleagues, and thank you very much for possibility to stay with you.
Good afternoon, sir. Welcome to our show. Dear viewers, we have another enthusiastic ilizarov surgeon from Patna, India. I would like to request Dr. Shamsul Huda, sir, to join with us.
Good afternoon. Thank you, Dr. Tanveer.
Good afternoon and welcome to our show, OSA. Dear viewers, today our topic is infection control by ilizarov. As because of this is a very important topic. So definitely, infection is a graveyard for all orthopedic surgeons, but we can overcome it by ilizarov. But how? Professor Mofakrul Barisar will show us that things that we can overcome all sorts of infection by using ilizarov. Sir, would you please share your screen with us? Professor Mofakrul Barisar, please.
Okay. Thank you, dear friends. Today, I would like to talk on a very important topic, which is very crucial for the all orthopedic surgeons. That is, I'll talk on today bone infection. What are the challenges from prevention to complications? I told you, dear friends, always love to show you the orthopedic capital. This is 2 days back. I was in my previous institute, our National Institute of Traumatology and Orthopedic. It's a very beautiful building, very impressive. Whenever you will be there, you will be able to understand what is our institute. So, diagnosis and treatment following 35 years of my personal experience in more than 5,600 patients. Look at this picture, left and right side. This infection for orthopedic surgeon is a complication. Hidden infection in a reconstructive surgery program are frequently underestimated. Many patients without any clinical, biological, or radiological signs or infection demonstrated based on bone cultures. Science moves forward, concepts are changing. EBM, evidence-based medicine, provides better knowledge that can be immediately used in practice. Now, let us see what is bone infection. Bacterial colonization of tissue with scars or not humoral immunity as it lost vascularity and become necrotic. You can see in the pictures, left side and the middle one and the right side. And if vascularity is lost, the bone becomes like a foreign body, which is a conductive to a surrounding inflammation. In the year past, and unfortunately to those who was and still remains a school of thought which consider bone infection in the same time of any other localized infection where the vascularity is maintained. This is a kind of illogical philosophy. No signs, in fact, the necrotic bone is without vessel, do not have blood, and not any drug or humoral defense can reach the infected bone. Even from a diagnostic point of view, it is recently observed that there is a waste of tests which are not at all useful for diagnosis or choose of the treatment. There are also highly invasive as CT scan and scintigraphy. A diagnosis of bone infection is relatively simple. If the orthopedic surgeon has the patience to examine the patient and order a simple plain radiograph, you can see in the left side the bones of the leg, and you can see the x-ray. In the right side, you can see the same patient's, another patient's leg. You can see by looking at these and doing a very simple x-ray, you can have a conclusive idea of what is the problem here. When a patient after fracture presents in tumefaction, that is, an action or process of swelling or becoming tumorous, pain and fever make the diagnosis highly probable. Of course, the differential diagnosis should include other pathologies, perhaps metastatic, but patient anamnesis or history is highly indicative. For example, you can see here, a leg fracture is treated with an internal plate and presents with an inflammatory reaction, with fever, tumefaction, and perhaps a fistula. A tumor should be ruled out easily, but infection is obviously likely possible, and it will not be scintigraphy to enlighten the physician to reach the diagnosis. You can see here in the picture, left side, in the middle and the right side, which is treated by gentamicin bits. It would be as if on a rainy day, one would call a chemist to analyze a strange substance falling from the sky. Accepting that bone infection to make in a context of necrotic tissue, where bone is necrotic and does not dissolve like any necrotic soft tissue, but becomes necrotic and can remain in with or decades like a foreign body, maintaining an ideal environment for germ proliferation, and it becomes obvious that medical treatment cannot be operative. Evaluating a closed fracture to be surgically fixed, risk factors for surgical fixation related to internal fixation are poor stability of the fixation construct, excessive periosteal stripping of devitalized fragments, which can become completely necrotic and therefore easily succumb to infection. Therefore, to avoid infection and bone necrosis, it is necessary to follow a few rules, and surgery can be performed in a logic manner and by expert hands. If one has never treated bone infection, they will never identify it, treat it effectively, and will ultimately lose the patient. Even in case of less aggressive surgical exposure, as in intermedullary nailing, the remaining done with instruments that are not sharp lead to accelerated burn necrosis of the medullary canal and of the overlying soft tissues, which can lead to bone exposure. It should also not to be forgotten that it is the soft tissues which plays a very important role in healing process. Infected non-union, you can see here 3 skin coverage. Look at the left side and look at the right side. Therefore, to avoid infection, and if the patient was treated for a high energy fracture with any fixation and the bone fragments are devitalized and more importantly exposed, a reconstructive effort is useless and perhaps dangerous. And if burying a cadaver under a thin layer of dirt, worms would come out immediately. Now, dear friends, you can see the quality of the bone here in all the pictures. Open fracture, you can see X-fix application, but the skin and the bone necrosis. The solution in similar cases should be to remove all devitalized fragments and devitalized soft tissue, and the process of soft tissue coverage procedures. Now, you can see bone and skin loss infected here. Once the patient has been stabilized, skeletal reconstruction can be carried out with whatever procedure the surgeon is comfortable with. If familiar with bone transport with external fixation, the surgeon can apply it for large bone defects, whereas for small defects, other methods are available. As for example, we can go for muscular technique, or we can go for vascularized fibular transport. Such steps has always been successful once the bone fractures have been stabilized and all necrotic tissue debrided. You can see here in the left side the discharging sinus, which is covered by flap, and patient was worried all the time with these kind of necrotic bones. This is evident in infected situation, and the surgeon does not need a special test to define the strategy. Now let us see, dear friends, case illustrations. 40 years old man, open infected wound with exposed implant with the dribbling pus. He was treated elsewhere with plates and screw. This is the common scenario in all the countries of the world, and especially the third world countries like our country. Look at this here, radiographic view and the face of the patient. During treatment, see the dribbling pus, how this is coming. And so for this kind of patient, for this kind of x-ray, you don't need to go for any special treatment or any special x-ray. Only a simple x-ray is quite enough for diagnosing the treatment of this case. Now, what happened? We have treated this kind of patient with ilizarov fixation. You can see the follow-up after 4 months, and you just can compare the left side, the right side. This is follow-up after 5 months. This is follow-up after 1 year. From this situation, from the left side, and follow-up after 1 year, the right side. You can see the same patient after 2 years follow-up. And this is, you can see the dribbling pus, infection, implants failure, and complete cure of the patient of the right leg. And he can squat very easily. Now, here you can see the chronic osteomyelitis of the right tibia with discharging sinuses for 3.5 years. Dear friend, you can see here the cavity of here and see the skin condition, visible sinus. Now what to do? If you go for saucerization or curettage without ilizarov, you cannot expect very good or excellent results. Then what we have done, this is the before surgery. You can see the formation here, the cavity. Now you can see the cortex here, whole AP view. And what we have done, we have treated this with the ilizarov apparatus. After 2 months follow-up, you can see. And the same patient, see here, radiograph, and this is almost healed, you can see. And this is after 6 months follow-up. Now, again, you can see the chronic osteomyelitis of the tibia fibula with multiple discharging sinuses. We have done the fistulogram to identify the, the channel or the canal of the whole bones. So this is the bone. You can see here tibia. This is a sequestrum which we removed, and then as a result, what we have done, what we have achieved, you can see here with biocompatible thin wires and then curettage and fixation with the ilizarov. And this is the fistulogram, non-united fracture. Obviously, whenever patient comes with chronic osteomyelitis, I always suggest to a patient to go for the fistulogram. And most of the surgeons, they don't like this, but this is the way how you can go through this, and how you can go, you can have a very good idea the pathways where the infection is passing through these. If you do a fistulogram, you can have a good idea, and on that basis, you can do the surgery. So this is the same girl. You can see, dear friends, after removing this sequestrum, now see, this is the she is fully cured, almost cured, I should say. So here again you can see the chronic osteomyelitis of right radius and ulna. Look at this. This is the sequestrum. This is the dead bone. And then patient came to my place. This is in 2015, 6 years back. And then what we have done, you can see lead radiograph after 2 months follow-up. This is sequential follow-up and this is the ilizarov apparatus. Whenever you apply ilizarov with the upper bone, that is the radius and ulna, the humerus, you tell your patient to take the dumbbell in the hand and go for exercises. And then you can see here from this situation, this is final follow-up after only 5 months. Again, another patient you can see here, chronic osteomyelitis, left radius and ulna with discharging sinuses. He was treated elsewhere by uniaxial fixator. And then I have removed all these things, put the ilizarov with only wires, and as a result, what you can see from this situation to this situation, patient is happy. Only a little bit restriction in the wrist joint. Otherwise, patient can utilize his hand very nicely. So this is one of the very difficult case, the reconstruction versus amputation. This is the scenario sometimes in the country. You can see what to do. This shattered bone, you can see here gastulo 3B, and in the old operation theater, we have seen by, the vessels, posterior vessels were okay, entry was gone. 13 years old girl, the parents came to me. At that time, I treated this case in Nitor, in our National Institute. First OR, look at this, and 14 days after the fixation of the ilizarov, one ring here with the telescopic, so that you can go for proper dressing. And then gradually after 28 days, you see nicely formed the granulation tissue, and after 2 months follow-up, we have grafted this one, and you can see the fracture was over 1/3 of femur also, and this is 2.5 months. This is the miracle. You can see after 5 months, the patient could walk. You see, this is just like you can see here living prosthesis. People like this, fixed here. Of course, patient is walking with her leg. This is only after 5 months follow-up. The same patient came to me, see, after 3 years follow-up. See, the same patient, you can see here, and look at the bone quality, tibialization. And then the patient from this situation to this situation after 3 years follow-up. And she's, happy, and the parents are happy, and at least just like a stick, living prosthesis, she's walking like that. So, dear friends, this is published in an American journal. Now, you can see another one, the infection. Infected fracture, gastulo 3B, which was treated by uniaxial fixator. Look at the heel, and at the same time, with the uniaxial fixator elsewhere, you can see the black skin and the exposed bone in the ankle and in the lower 1/3 of the tibia. And look at the calcaneum, and look at the quality of the bone with uniaxial fixator. Then only you should have to see your circulation. If circulation is okay, more or less, either anterior tibial or posterior tibial, then you can go for gradually correct. I put the see, keeping the uniaxial fixator, try to apply the ilizarov only with the wires, and then look at this. From this situation, this is after 4 months follow-up, and look at this leg from knee to ankle. And then compression and distraction device by ilizarov technique. And fortunately, he's a college teacher. You can see here, dear friends, look at the back of the sole, the calcaneum, and look at the ankle. And then sequential, you can see after 7 months follow-up, look at the bone quality, and then 9 months follow-up. Of course, the flap coverage was done here, and this is the situation. A college teacher lecturer that is in outside Dhaka, and this is the situation. Now see, after 11 months follow-up, and the patient is happy. He can walk without any support, a little bit limping, that does not cause any problem with the patient. You can see here, again infection with, this is a case of, you can see here, if you floating knee, you can see here floating knee, there are classifications of Fraser classification. See the lower 1/3 of the combination, condylar fracture, see here, and the tibia, uniaxial fixator, treated elsewhere for 2.5 months, then came to my place with infection. Again, the problem, how we manage this one. See, after 2 months, if you properly apply the ilizarov in the femur, and here you can put the chance pins, and in the middle and the lower third, very easily you can put the biocompatible thin wires. Now, you can see from that situation to this situation. And in here, we have, this is the tibialization of the fibula. And during treatment, and this is, you can see after 5 months follow-up and clinical appearance of the patient from that situation to this situation. These are the salvage. You can beautifully salvage all the things when you have ilizarov properly you apply, you can salvage the limb. Patient is happy. Now you can see, just compare here, dear friends. This is fibula, see, and this is see here, tibialization. Fantastically, patient is happy and she's walking nicely with his leg. See again, infection, LLD, gastro 3B exposed bone. These are the challenging cases with uniaxial fixator, treated elsewhere. Then look at the bone quality and look at the fracture geometry. You can see here. Then again, dear friends, just you see the rotation of this. If you look at this, the situation from here to here, and we are pulling the bones in this way by putting the one ring here, and one ring here. And sequential X-ray, you can see the follow-up by pulling the bone fragments crossly with olive wires, and gradually you can see during treatment, and this is after 5 months follow-up. Now you can see from this situation, very bad condition. These are the difficult cases, lower one of the tibia, exposed bone. Even then, you don't need to go for any flap cover here. Of course, you can do a flat cover. If you know that one, that is good.
I think sir is disconnected.
Yeah, dear viewers, we're waiting for reconnecting Professor Mofakrul Barisar, and that was an excellent presentation. Hope Professor Barisar will connect with us within a few moments.
So I think there is some network congestion, and in the meantime, I request all the viewers to have patience, listen to such a wonderful lecture by Bari sir. Infection is a major problem in all the traumas. You get so many cases of infection, pre-surgery, post-surgery. So it's very important. You should have a good knowledge, experience, good, really learning how to handle such cases. Thorough development is very important. If you get big wounds, infected wounds, you can do wound transport, you can do the treatment. Elizabeth is a wonderful medical device in all these cases. So, Dr. Tanvir is back.
Yeah, yeah. Thank you, Dr. Udavai.
So,
Yeah,
I was just saying that to viewers that getting infection cases is actually there's so many cases of infections post-traumatic and even after surgery. So you must have a very good knowledge of how to control these infections, to have a good treatment and tissue and bone regeneration with Elizarov. There's so many cases over here. Yeah. Even after you remove the rings, you get cases of infections of intact. You should get a very good training and knowledge of all this to handle these things. But are so magical cases for us.
yeah, yeah, definitely. And I think Barista probably don't use that much of flap coverage.
Yeah,
Uh,
yeah,
he uh, he just apply the Elizarov ring there and wait for the granulation tissue, then go for the skin graft, and uh, only Elizarov can solve the flap coverage also, and that is a
exactly.
great thing.
Yeah,
Where there is no plastic surgeon is available, then
yeah.
the orthopedic surgeon can cover that tissue loss by Elizarov also. That is a magnificent thing also, I think.
That is management. Exactly. So when you have Ilizaro, you can do bone transport as well as tissue generate along with bone transport. You don't need to go and flat.
Yeah, yeah, that is a great thing. Yeah. I think Barisar will connect within a few moments. Dear viewers, due to the network jamming, Professor Mafakhrul Barisar disconnect with us. And today our topic is the infection control by Elizarov. Dr. Shamsul Huda, sir, I want to ask you about the procedure in your country, in India. What you are doing in that case where there is a huge pass and with implant in situ. Is there any other option except Elizarov?
Yes, people go for a bone debridement and then bone cement beads. You put bone cement beads over there to control infection. And you can, if you don't have Ilizaro, you can go for Maslach technique also for this portion of the bone. So bone cement application is very good in this techniques, and the basic thing is thorough debridement. In any case, whether you apply Ilizaro or an X-Fix or nothing. If you do thorough debridement and bone wash, bone goes away, then you have a choice whether you can fix with Ilizaro bone transport or you can go with plate and bone grafting.
Yeah, yeah,
So
that's
bone
great.
surgical is very
Uh,
common.
Yeah, we know that you are doing Elizarov, lots of Elizarov, and you are doing a great job in your country. Then, what type of Elizarov you are fixing in case of open fracture, where there is flap is needed, but a plastic surgeon is not available?
Yeah, that is a very actually very important question. We get at periphery centers, plastic surgeons are usually not available, and when you get exposed bone and the bone is necrosed, bone is dead, and you have to remove the bone. So in that case, if the bone is alive, then only we need to give for flat. If the bone is dead, then in that case, you do 42 minutes thorough department and you do bone transport. I do bone transport with the video in maximum the cases, and finally, I never need to go for flat. The tissue regenerates very well with this. Even if I've done within 7 inches of bone transport in tibia.
Oh, but the maximum 7-inch transport in tibia.
Yeah, yeah.
Oh, that's great. That's great. Then how long it takes
Okay.
for
The
7-inch bone
complete
transport?
removal takes around 1.5 years in that case. So 7 inches case.
Oh, you made it unifocal or bifocal transportation?
In long transport unit, bifocal.
Okay, that's great. Then first we have
Right.
to cut off the dead bones.
Dead bone.
Then we will fix the upper and lower part of the bones with the Elizarov, and we'll continue the dressing. And then
Yeah.
after that, we will skin graft, do the skin graft, and then we start the transportation of the bones.
Skin graft is you do bone removal, vegetable bone removal. Skin graft is not needed in all the cases because first we do
Okay.
dead bone removal and do third department. The second stage we do bone transport, and as the bone approximates, the soft tissue comes along with it. So graft is not
That
needed.
is a very important question. I face lots of difficulties there. I want to
Yeah.
ask you, before skin grafting, you start bone transportation, or after skin grafting, you start bone transportation?
Skin grafting is not needed in many of the cases actually.
Okay.
So you have a big bone gap. You do a bifocal cortical male both levels. The gap is here. When you approximate the bones, then finally you don't need a skin graft. Lastly, last is if some amount of bone is exposed, then you can just do a patch of graft only.
Oh, that means during the bone
Do graft, do
transportation,
graft.
the granulation tissue will transport also.
Exactly. It comes along the soft tissue, comes along the bone. So you don't need a
Okay.
skin graft also. Yeah.
That's a great thing. Then we can start it in the day fifth or day sixth.
Exactly, exactly. First, you have to do dead bone removal. You wait for a few days to see if there's no pus. Then you do a correctomy. After that, you can start day 7, day 6, day 7. I start day
Yeah,
7.
yeah, yeah, definitely. We all know that if we done the corticotomy, it will increase the blood circulation, and during bone transportation, the vascularization increased so that there will be less chance of infection, and the granulation tissue will be more.
Right,
So
right,
that's a
right.
great thing. That's a great
Exactly.
thing. We can manage it, and in that time, the patient will be mobile.
Mobile. I've got patients who are on bed on external fixator and dead bone for 6 months or more, even 1 year. And after you do ilizaro, you just make the patient walk next day. So he feels my leg is safe, gets great level of energy. So walking is very important. For patients,
Yeah,
the
yeah,
psychological boost up before regeneration boot. That can only done with ilizaro
that
only.
is very important. Exactly, exactly. That is very important. One more question. Do you use antibiotic during that time when we apply the ilizarov?
Antibiotic I usually give just post-op around a week only. If a thorough department is done, antibiotic is not needed. Remove dead bone as well
And
as dead tissue. Yeah. No debris
okay,
has to be there. Yeah. Antibiotic doesn't have a
because
role.
of
Yeah.
yeah, yeah. Ilizarov itself works against the infection, so there
Exactly,
is
exactly.
not that much antibiotic is needed. So the
That's,
another
that's like,
benefit is that the less use of antibiotic. Yeah.
exactly. Because it's very well said that infection burns in the tissue generation, the part regeneration.
Yeah, yeah, that's a great thing. Do you add anything special for the surgical toileting of that open fracture in that case where Elizabeth you put
Nothing special, nothing special.
the normal surgical toileting that we
Normal,
are using the
normal,
povidone, the normal saline,
normal distance,
hydrogen
normal
peroxide.
saline.
Yeah, yeah.
Then use for debridement, we use hydrogen peroxide, grading, etc. And lots of NS. Washing is important.
Okay, that's great. That's great. So we can make a special protocol for that things, the management of open fracture by
Exactly,
Elizarov, and
exactly.
mm, uh, definitely it will helps us a lot. And all over the
Uh,
subcontinent, we can easily maintain that protocol also.
exactly. In a few cases, just to add, in a few cases, when you see that there is a compound fracture, open fracture, and the bone is viable, and if you're doing a primary trauma, then in that cases you can just apply a graft or a flap after 7 to 8 days when you see that there is no infection on the zero. When you don't have to do
Yeah,
a bone transport. Yeah.
yeah,
I've
yeah.
even used
That's a
back
great
over
thing.
zero. That's very difficult actually, but I've used in few cases. Back.
Yeah, back is another thing that is very much useful and helpful in that
Exactly.
case. We are also using the back. I think Barrister facing some difficulties. I think I
Right,
have to
right,
knock
right.
him. So wait a minute, and I will knock him within a few seconds. Yeah.
Please. So friends, you have to be very meticulous and very decisive whether to use ilizarov as a primary device. If you get a bad crush trauma, you have to wait for a few days to see if the limb is surviving, if there is a vascular injury. So wait for a few days, you can put on a slab or a switch. I just put slab, wait 3 to 4 days if the limb is surviving. Then after that we decide if the bone is viable, then apply ilizarov, few dressings, then apply rack or skin graft or flap. If the bone is non-viable, it is dead, we can remove the bone and go for bone transport. And then no graft or flap is needed. So ilizarov is a wonderful device for infection and bone loss or fractures, open fractures. You can always make the patient walk next day, fluid bearing.
Eh? Can you see me?
Yes, sir, we can see you, sir.
Okay. I just entered then and there.
Yes, sir.
I don't see Tanvi.
He's here only. He was just trying to knock you, sir. You're here only.
Tanvi, I
Yeah.
don't see Tanvi now.
Yeah, he was here. He was here. Sir, you can continue with your slides.
Continue. Next time continuing. Okay.
Dr. Tanvir is here. He was just trying to call you, sir.
Yes. Now you can see this one.
Yes, sir.
Starting just I go fast. Now this is visible. I have what I have finished. Now from this you can see now.
Yes, sir. Yes, we can see you, sir, clearly, and we can hear you loudly,
Now,
sir.
now,
No
now this
problem.
here you can see 23 years old man. Here, see you got gastilo 3B, exposed bone. Then what we have done? See this case. See this case. See this case after treatment, and this is the clinical appearance of the patient. This is the case, 45 years old, treated elsewhere with exposed bone, infected bone, with exposed plates and bones. See here, very big gap. Then we have put a guide wire. Look at this. And we have gone for lengthening. And this is the clinical appearance of the patient after treatment time. 1 year, it took 7 months. This case, old man, exposed bone. Look at this left side. And this is the X-ray, uniaxial fixator. And then look at this very big gap in between the second and the third ring. 8 months follow-up, 2 years follow-up. From that situation to this situation. See this? Very good. Full consolidation. Look at the left side, full exposed bone, and then after treating by ilizarov technique. And this is, I would like to show you this one. He was treated several times in different places, putting the nails and at the same time gentamicin bits. I personally, I have seen a lot of cases that people are here doing in my country with this. And there was a non-union, the cases that I have seen in my country, and I have fixed, I have removed that one. And if you beautifully apply the ilizarov, then the patient with ilizarov in the thigh can easily walk. And from that situation to this situation, you can see again 55 years old man infected. What I am showing you, these are all the cases of the infection. Look at this: bilateral tibia fibula, and then clinical appearance of the patient. Again, double plating with infection. Down elsewhere, you can see infection. Then infection. There is in a village. Look at this. After 3 months, double plating, segmental bone, infected bone, radius ulna. Look at these with rush nail and plates and screws. Again with ilizarov. How we have applied, you can see the 1 ring, 2 ring. This is the olive, this construct. And this is the final follow-up. You can see good consolidation. Again, bed scar with exposed plates. With exposed plates, atrophic non-union. Same. Again with ilizarov. This is also published. And the boys are always, by ilizarov, fantastically, they can use the ilizarov. Look at this. This is the case, 2 years old boy. And you can easily put the ilizarov, go for 3 ring constructs, and for lengthening, putting the guide wire inside. And after 8 months follow-up, now see the infected one. Infection burns in the fire of regeneration. Look at this, very beautifully corrected. And it gives a guarantee of not doing the recurrence again whenever you are putting you are doing with ilizarov surgery. Now, after 1 year and 3 months, look the bone quality. Okay, infection. Same again with infection, osteomyelitis, with angulation, and then just put the ilizarov here in the console wear and fix it with ilizarov fixator, and then this is the consolidation after only 4 months follow-up. This is the case. You can see discharging sinus at the age of 3. Father and the son came to my place with chronic osteomyelitis with pathological fracture. Look at these, dear friends. This is the bone, this is the pathological fracture, and I have done nothing, only fixed with ilizarov apparatus. No curettage, no intervention. And then this is, we allow the patient to walk with this first step surgery. The patient can easily walk. The children can easily bear the ilizarov apparatus without any kind of complications. And see pathological fracture, and the bone is totally healed after 5 months. And this is, see the follow-up after 11 years. After 11 years. From this situation to that situation, just see 11 years. Then there was a LLD. Then second step surgery, I have done the same boy. You can see, and I have removed this. So gaining of the full length, you can see from femur and tibia. This boy, this is the highest 11 years follow-up, 12 years follow-up, you can see here. This is the boy. This is the boy, and this is the same boy. You can see here. Here, pendifacial osteomyelitis, again infection with pathological fracture here. Again, you just fixed with ilizarov apparatus, and then you allow your patient to walk, see the bone quality and healing process, and see this is the view of the lateral, and this is the AP after removal of the apparatus. This is after 6 years follow-up. Look at this quality of the bone. That is the left femur, and this is the left femur. Nothing, only you allow your patient to do the exercises with the ilizarov apparatus. Again, CM, chronic osteomyelitis, C, here and here, lower 1/3. See the skin condition, see the deviation, see the deformity and the skin condition. And at the same time, first step surgery and the second step surgery. And finally, you can see the radiograph. This here, this is the before treatment, double fracture, pathological here and here. And you can see the quality of bone. Here is the effect of ilizarov, the principle of ilizarov apparatus, principle of Elizarov's law. And this law, how it works, here see, slow and steady traction on a living tissue creates a stress which is metabolically activated in both the biosynthetic and proliferative pathways, depending upon the vascularity and the functional use. This is the Ilizarov law, principle. Why Ilizarov? I always tell, see, why Ilizarov? If you think about this Ilizarov, all alphabets, I, you must have little intelligent, lengthening, you can control the infection, you can control the zigzag, that is deformity. A, you are getting angiogenesis all through, adaptable, are reliable, you have lots of opportunities, and finally, you are getting victory, that is, this is a versatile, whatever you want, you can do. And Ilizarov always serves 4 purposes. It gives mechanical stability. Whenever you are giving mechanical stability, you are getting compression or distraction around the line of compression and distraction. You are getting billions of cells around the line of compression and distraction. And I told you 330% circularity it increases. And then finally, I'd like to tell, always like to show this one. What I have shown you, this is the evidence, this is the science. And of course, at the same time, it depends on the surgical skill of the patient. And with the Ilizarov surgeon, we can fight with the infection if we follow the principles and philosophy of Ilizarov. And we are doing in my country. This is my teacher, my mentor, successor of Professor Ilizarov, Vladimir Ivanovich Shevtsov. We are conducting a workshop in India. That's why I'd like to show you for my Indian friends. Thank you very much. Thank you again. This is, we conducted a workshop and seminar in 2019 with giants of Ilizarov Center, Novikov, Shevtsov, our teacher, Professor Shamsuddin, Borjunov, and Klushin. Only one man who is fighting Professor Klushin from the Ilizarov Center. And this is Shevtsov and Gubin. And these are my publications. Thank you so much for your kind attention. Thank you again.
Thank you very much, sir, for your excellent presentation and time-demanding presentation. It's because of many patients are suffering from infection, but they are not coming to the proper person. And if we apply the Ilizarov, then we can easily can take the recovery from the infection. Now, I would like to request Professor Novikov sir to share his knowledge regarding the presentation of Professor Mufakarul Bari sir. Professor Novikov sir, would you please share your knowledge?
Dear colleagues, thank you very much, Barry. Where you take these cases, and спасибо большое for unique experience, because just now so many doctors in your country, in another country, all of the world can see heaviest difficulties situation problem with infection of bone. We can really support, but only one problem. This is time of doctor, time which doctor needs spend for patient, because like any Elizarov's patients, infection patients need attention from the doctor. And you ask about antibiotics. In our experience, when we start treat infection situation, doctor usually not use antibiotics. If this is clear, patients, for example, shortening, and we try equalized some lower extremities, upper extremities, and then coming problem with small infection of soft tissue near the pins, yeah, immediately we start support of this patient with antibiotics. But when osteomyelitis already in the inside of treatment, and we need to start treat this patient with ilizarov support, usually very strange, usually patient not use antibiotics. This is effect of ilizarovs, where find body forces, power for fight with infections. And Barry, you are a great surgeon, because this is heaviest cases not only for Bangladesh. This is heaviest cases, I think, for all of the world. And like a great surgeon, you really support for uh, all of this situation. Thank you from my heart, from Elizarov Center, because just now you are excellent follower of Elizarov philosophy. Thank you.
Thank you very much, sir, for sharing your knowledge. Now, I would like to request Dr. Shamsudhuda sir to share his knowledge regarding the infection control by Elizarov in India.
Thank you, Dr. Tanvir. Thanks, Bari sir, for showing wonderful cases, great cases, sir. We have already learned from you, sir, and Naviko, sir. So, as we all know, we get so many cases of post-traumatic, post-fixation infections in India, post-plating. There's so many cases of rumen pus, and we have to go for ilizarov, because ilizarov is the only device that can cure all these sort of infections without any graft, without any flap, or just flap in a few cases only. And so I say that if it is a primary trauma cases, you can just put an ilizarov and make the wound heal. But if it is a wound, big wound gap, big wound, you have to do bone removal and do bone transport. And with bone transport, we usually don't need any sort of graft or backup flap. So we get so many cases. I've done around 7 inches of bone transport with ilizarov in case of infection. Sir, I have a question from you, sir. I've seen in a few cases after bone transport in tibia and femur, because some patients are coming from very distant places, so the follow-up is not very regular in cases. So post removal of the ilizarov, we get pin tract infection for so long, or even infection of the docking site. Patient just bit of coronal pus is coming from one or two sides for months or years. So even after doing debridement, it continues. What to do for that, sir?
For me, question to me or to question to Novikov?
So both, sir. First
Question
you, sir.
to
So, Elizarov surgery, if once you have finished that one, you must meticulously follow up the patient. Before doing these cases, infection cases, big gap non-unions, you must counsel your patient all through, so that patient cannot blame you.
Right, sir. Right, sir.
Patient cannot blame you. Sometimes it happens that you told patient is not coming properly due to financial constraint or any other problem. They are telling all the time, sir, I cannot come. The time that you have given me, I cannot come. So before doing that, you must properly counsel your patient. This is you should have to do. You should have to check your apparatus. Proper dressing, 7 to 10 days, proper dressing. How to do the dressing, I show my patients. Patient relatives, I always show them. Otherwise, it is very difficult to maintain the external views of the apparatus. I tell them always, if you don't cover this with gauze, sterile gauze, if your room is open 24 hours, all the windows are open 24 hours, what will happen? All infections are coming, dust will come in your room, and the room will be dirty totally. Same case I tell the patient. That's why whenever patient, before discharging to my place, I give them the cover and a guidebook so that they can follow, written in Bengali, so that the poor people, they can follow it. This is the very important things. How to live a life with ilizarov apparatus. This is very important. Not that you have done the cases and finished. No. Starting from the day one, you have finished your surgery, then till removal of the apparatus, you must be meticulous, and at the same time, the patient's relatives and patient must be meticulous. Otherwise, you will face problem, patient will face problem. And big gap, I always put the guide wire so that it cannot deviate. If you don't put that, you will get the deviation. Patient, you have released the patient has gone, and after a few days, he will come with the displacement. And no money, nothing. What you will do? Again, you shall have to do that one. So these are the counseling points. Very important things for the ilizarov patients. And very important, time consuming, everybody is telling. Time, orthopedic surgery is time. Time consuming, this is the, yes, this is good. But at the same time, outcome is very good with ilizarov apparatus.
Right.
Outcome is very good. You cannot deny that one.
Yeah. Perfectly agree, sir.
Outcome is very good if you properly follow up everything. That is good. As for example, you have put the plate and screws or interlocking lanes. Okay? Patient feeling comfort. After 3 months, patient has come. Sir, discharging is going on. Infection, swollen. What you will do? You give me the, again, antibiotic. Young chap, 20 years, 25, 30 years, antibiotics. Wash, wait, infection control. Then you will put the, again, plate and bone grafting. And whatever the time here. Oh, these are the, controversial things. Controversial things on this. So, I love ilizarov because what I'm doing, Tanveer and
Yes, sir.
Shamsulullah, I am doing totally. I am doing all kinds of deformity corrections. I'm telling you, all kinds of open fractures, plating and screws I am doing. Just for example, I have done one case interlocking. I have taken 1 lakh taka from the people, patient. After a few days, he has come. Doctor Sahab, yeah, kya hua? Infection? Then I can change that one. I can take less money. I will do it freely because ilizarov in my hand. These are the positive sides of the ilizarov. These are the positive sides of the ilizarov. Principle, most of the orthopedic surgeons, they don't know the ilizarov principle. Slow and steady traction on a living tissue, very important. Slow and steady traction on a living tissue creates a stress which is metabolically activated in both biosynthetic and proliferative stage depending upon the vascularity and the functional use. You have a vascularity, functional use, then you will get a very good result. This is the principle of ilizarov. Whenever you are doing ilizarov, you must keep it in your mind. This is the principle. I must follow that one. Otherwise, no. Putting the wires, don't check. All wires are, this is bumping from here to there. Nuts are loose. Patient will cry. Doctor Saab, ye to pain hai. What to do? But you don't check yourself. You must check. Teach your patient, teach your, relatives. You must do this check. Just like an aeroplane. I tell you, it's aeroplane. Patient has come to me. By this time, 10,000 aeroplanes are moving in the world. If one falls, crash, then what will happen? 3,000, 300 or 400 will die. This is your apparatus, just like aeroplane. Just like aeroplane. If you unlock or untighten your nuts and bolts, there will be painful situation. Whenever stable, no pain, nothing. And outcome is very good, very good. So we don't need to afraid of the ilizarov apparatus. I feel proud when I apply the ilizarov. I feel comfort. I get a strength when I apply ilizarov because I know outcome is good. Outcome is good, I know. That's in my hand. What I'm doing and what I've seen in Kurgan Center. And that is, they have changed my life, by doing this. I have changed my life totally on the basis of ilizarov. Infection, any kinds of deformity, limb lengthening, any kinds of deformity. As for example, you have done the total knee, chikia, infection. You need to go for arthrodesis. Ilizarov is the good. Charnleys, other things, compression, but ilizarov is the good. So that's why the principle is very important. I salute always all these men, this gentleman, Mr. Novikov. I salute them always because they have done something for the human being. The man, those who criticize the system of ilizarov, they don't know the proper application of ilizarov. That's why they criticize. If you follow the ilizarov paradigm, that is another thing. And my message is, once if you learn ilizarov, there will be no monetary problem. You will get satisfaction. Money, deformity correction. I always repeatedly tell, easy, difficult, and impossible. You can do the impossible things with the ilizarov apparatus. No other alternative way. Third world country, don't think about the SUV, don't think about the tailor special. They are costly, yes. Costly for costly people you do. But for the poor people, you can apply this ilizarov technique very easily. Very easily.
Ну, сейчас уже комментарии, я думаю.
Okay, thank you very much. I have taken time.
Thank you very much, sir. We all know that we can make impossible thing possible by Ilizarov, as because of Ilizarov is a faithful friend of all orthopedic surgeons. Now, I'd like to request Professor Novikov, sir, to share his knowledge regarding the pin track infection. What we can do if we face some pin track infection, like us, the young chaps, then how we can manage that thing, sir? Sir, you have to unmute yourself, sir.
If I understand, Barry, please help me. Just now, questions about pin track infection, simple lengthening, simple correction without osteomyelitis, yeah?
Yeah.
Usually, all of our patients has this problem, and this is a problem, I think, of condition of immune system. But usually, on the first surgery, we pass little bit extra wire. For example, for lengthening, enough 2 wires, but me and my colleagues pass minimum 3-4 wires. Why?
Yes.
Because during the way coming pin track infections. If with change bandages, if cleaning of all of segments, we just now wash with soap skin, place all of apparatus, and first day we not give antibiotics. We need check during minimum 1-2 days. If next day situation little bit was not we not have improvement, we start treat with antibiotics. After 3 days, if we haven't positive dynamics, we remove all this problem wire because we have minimum extra 3 wires, and we continue with our treatment without any problem. And pin track infections, this is problem. This is not complications. All of our patients, little bit more, little bit less, has this situation. But this is problem. This is information for activities of doctor. And I am happy doctor because during 40 years, I haven't patient with osteomyelitis, clear patients. But all of my patients has pin track infections. And you see, just now, Dr. Barry explained about plate. If some screws has infections, we cannot support with antibiotics, must remove plate. If these bad situations come, we cannot go away. With ilizarov frame, we need spend attention because I can something do. With plate, with nail, I can't. With ilizarov frame, I can change so many things. For example, sometimes you, Dr. Barry, absolutely right. This is very delicate music, and when we have music instrument, we need to check tight of tension of wires. Надо натянуть струны, чтобы инструмент хорошо играл. Барри, помогай. This is our message, not for all of doctor. This is, I want to repeat again, this is magic message only for doctor who is ready spend his honor time. Because all of Western methods, next. Case is finished in the operation theater. When doctor put plate, when doctor put nail, next then he can live from these patients. I cannot live, sometimes many months. This is patients like my neighbor. I stayed with him, with patients till remove of frame. This is, I think, situation when doctor needs think. He is ready spend time, big time, because some doctor not is ready wait, because next patient will give, this is true, money is honey, but our patients, our result will after 6 months, sometimes after 1 year. And all of patients has pin track infections, but if you will spend time, nobody will have complications with infections. And very seldom, just now, very seldom, we have some situation when patient need to shift to the infections department. Usually we remove this situation during 2-3 days. Sometimes, like prophylactics, we give because our government will ask, because we have list. If infections come, if during 3 days patients have a high temperature, some discharge, some stuff, I need, with protocol, I need prescribe antibiotics. But this is sometimes I feel enough, remove wire and forgot.
Okay. Thank you very much. Thank you very much for sharing your precious knowledge with us. Thank you, viewers, for being with us. And I would like to thank Raj TV for helping us to arrange this type of academic program, and definitely Renato Pharmaceuticals Limited, Bangladesh Limited, for sponsoring this type of program. Dear viewers, I hope we will meet you in the coming Friday with another magical ilizarov topic. Till then, I'm Dr. Mohammed Tanvir Shah saying bye-bye to all of you. Bye-bye.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.